Greetings, bienvenidos. In the name of the National Latino Behavioral Health Association and the National Latino Prevention Technology Transfer Center, we welcome you. Our National Hispanic and Latino PTTC is happy to partner with the Central East PTTC, the Central East ATTC, and the National American Indian Alaska Native PTTC to bring you a 4-part virtual learning session titled What LGBTQI2S plus BIPOC want prevention professionals to know. Today's session subtitle is Understanding the Historical Information Behind the Challenges and the Risk Factors of the LGBTQI2S plus people of color. Next slide, please. This is a disclaimer and information about the projects and fundings. My name is Dolca Michelle Zelaya. I am the project coordinator for the National Hispanic and Latino Prevention Technology Transfer Center. I will be your host for today's session. Now, please allow me to share some brief instructions about today's virtual learning session. A copy of today's presentation will be available after the event. The lines will be muted throughout the presentation to minimize background noise. When we get to the Q&A portion of our session, you will have an opportunity to ask questions by clicking the Q&A box, and the moderator will present your question to the panelists. We will ask you to fill a brief survey at the end of this event. This satisfaction evaluation is important to the work we do and provide us with the opportunity to improve our training efforts. Although we are not secure continuing education trainings for this event, we plan for future events. A certificate of completion will be available after this event. So let's begin. Next slide. This is the ADTC Map. The ADTC is a multidisciplinary resource for professionals in the addiction treatment and recovery field. Established in 1993 by the Substance Abuse Mental Health Services Administration, SAMHSA. The ADTC PTTC network is comprised of 10 domestic regional centers, 6 international HIV centers funded by PEPFAR, and 2 national focus areas and a network coordinating office. Next slide, please. Now you are seeing the PTTC map. The PTTC is a multidisciplinary resource for professionals in the prevention field. The PTTC network was established in 2018 by the Substance Abuse and Mental Health Service Administration, SAMHSA. The PTTC network is comprised of 10 domestic regional centers, 6 international HIV centers funded by PEPFAR, and 2 national focus areas and network coordinating office. The ADTC and the PTTC network serve the 50 states, the District of Columbia, Puerto Rico, the US Virgin Islands, and the Pacific Islands of Guam, America, Samoa, Palau, the Marshall Islands, Micronesia, the Mariana Islands. The international HIV and PTTC serve Vietnam, South Asia, South Africa, and Ukraine. You will receive a copy of the slide presentation, and you will be able to click on each logo to learn more about the centers and the educational materials that are available. Now it is time and an honor for me to introduce the moderator for this session, Ms. Princess Walker. Ms. Walker graduated with a dual degree in psychology and a health administration and policy program with a concentration in public health from the University of Maryland in Baltimore County. So Princess, we are happy to have you and all the panelists. We want to welcome you, and please, the floor is all yours. You can start the presentation.
Thank you so much, Dolca, and thank you all and everyone that has joined today's webinar. We are so honored to have each and every one in this room, and to the panelists, thank you in advance. As Dolca said, my name is Princess Walker. I am the Technical Assistance Manager for the PTTC. Our panelists for today, our first panelist that we have is Anna Marble Jones. She's an Oxford House Resource Coordinator in the DC and the Maryland region, which is a nonprofit that services 3,336 self-help recovery homes. In addition to that, we have Dimitry Garner, who is a peer health recovery specialist at the emergency department. Following that, we have Dr. Matt Ignacio. He is currently an assistant professor at the Arizona State University School of Social Work, located in Watts College of Public Services and Community Solutions. Last but not least, we have Dr. Carlos Parvo, who is the clinical assistant professor at the Department of Health Policy and Behavioral Science at the School of Public Health at Georgia State University. Without further ado, again, thank you, panelists, as we proceed with our four-part series, What LGBTQ2S BIPOC One Prevention Professional to Know. To move along the conversation, the first question I want to pose to the panelists is, can you please tell us a little bit about yourself? How do you identify? Where are you from? And what do you do? What are your roles? Want to start with Anna.
Hello, and I would like to thank the Prevention Center for having me here today. My name is Anna Mabel Jones, and I am a woman in long-term recovery. And what that means for me is I haven't used a drink or a drug since August the 30th, 1999. And because of that, I stand here today to speak for you, to let you know that I do identify as African-American woman. My pronouns are she and her. And I was born and raised in Washington, D.C. I now live in Laurel, Maryland. So there's been a lot in dealing with prevention on both sides when it comes to that. And then some of these struggles as being an African-American woman in recovery. What I do now, I'm honored to speak about is because of surrendering, and being in recovery, I am the resource coordinator for Oxford House. So I'm able to work with people. Oxford House is a national agency worldwide for recovery housing. So I'm able to work with people who are ready to become productive members of society and start living again and doing things that are positive. We're really active. The success rate that attracted me to living, I'm an alumni of an Oxford House too. So I'm living in an Oxford House that helped me because it's peer-to-peer support. So who better to know your behavior than someone who's been through it? And in that process, I stand before you here today. So thank you, Princess. It's an honor to be here.
Thank you so much, Anna. I really appreciate your participation. Dr. Ignacio, the same question is posed to you. Could you please just tell me a bit about yourself? How do you identify? Where are you from? What do you do and the role in which you play?
Great, thank you. Good morning, everyone. My name is Matt Ignacio. I am a tribal member of the Tahana'a'ata Nation, which is a tribal nation located in what is now Southern Arizona. I'm so honored and excited to actually be on my traditional homelands here in the city of Tucson. Chukchan is actually, it's an O'odham word. Tucson is derived from the O'odham, our language. So I'm home in Tucson. I just finished up a PhD in social welfare from the University of Washington in Seattle a year ago, 2020. It's a great year for all of us, right? And I just about to start my second year tenure track as an assistant professor at ASU School of Social Work at the downtown Phoenix campus. So that's a lot. That's how I identify, that's where I'm from. And my role, let me just also close with this part. I think I'm grateful to be here because I can pull from 21 years of experience working in HIV prevention with Native communities, specifically as a national trainer funded by the CDC, to fly out over 15 years. Part of my career was to fly out to far off places like I had heard about in South Dakota and Rhode Island, urban communities of Dallas, of Denver, and also got to work with Alaska and in Hawaii around HIV. And if you know anything about Native communities, you know, there's stigma. Stigma is present around HIV, around LGBTQ individuals. I'll talk a little bit about TwoSpirit and what that means a little bit later. But I'm honored to bring that information forward and talk about the great work that community has done and will continue to do. Thank you.
Thank you so much. I appreciate it. Mr. Dimitry, can you please answer the question as well?
Yes, thank you so much. And I want to thank PTTC for inviting me and being in this space, and for all the panelists. Thank you. And I'm such an honor to be a part of this, great discussion coming up in the next weeks prior to this one. So like I said, my name is Dimitry. Actually engaged in my recovery for the last 3 years, upcoming 3 years. I am at what they consider at University of Maryland, Baltimore County as an adult learner, but I consider myself as continuing education that never stops. So right now, being engaged in my recovery, I work at a wonderful hospital called Franklin Square, part of the MedStar system here in the metropolitan area of Baltimore, Washington, D.C. And we have the largest emergency room department in the state of Maryland, with serving over 100 beds and a psych ED as well. So being a peer recovery specialist, working in the hospital setting, different from different roles of other peer recovery specialists that work in other environments, I get to perform brief interventions with people that look like me, the people that suffer from the disease of addiction, of all socioeconomic backgrounds, and also of all different orientations. Orientations that come through the door are from all of the LGBTQAI, and what I learned from Dr. Matt over here, TwoSpirit. We do have Indigenous people in our area that come in, and to see the disease of addiction as it unfolds, no matter what your orientation or skin color may look like, it affects us all. And hits all parts of not just the family dynamics, but also our social dynamics as society. So I get to actually see it from hands-on experience working in the field, and also in the clinical aspects of actually studying the disease myself in school. Thank you.
Thank you so much, Mr. Dimitri. I appreciate your thoughts on that. And last but not least, Dr. Carlos.
Well, good afternoon, good morning, depending where you are. I'm glad to be here today. It's an honor, and I'm actually very excited about anything to do with LGBTQ populations, or what I like to refer to as queer populations, where I think it's more inclusive in many respects. I'm a Latinx person, first generation college graduate. I'm an immigrant and cisgender gay male. That's who I am personally. Recovery is something that has been part of my immigrant life all my life, actually. My father was an alcoholic, so I'm a child of an alcoholic. I'm married to someone in recovery. I have a huge network of friends who are in recovery. So I was raised in some respects, not only as an immigrant in a very socially isolated community in Massachusetts, a textile mill city, but also I travel in circles with recovery. So for me, this is a very important topic. I've lived in different areas in Texas, New York City, to I've been here in Georgia for about 15 years. I think for me, the personal side is what really matters to me is my frustrations as a practitioner. I started doing this work as a community organizer. I was doing this work when there were no interventions for HIV. We were just passing out condoms and doing health fairs. So I've been very frustrated as a practitioner about the role of data in grant writing and how we actually had to prove a need. And if there's no need, how do you actually get the funding? So that frustration stuck with me for a long, long time. And my focus is really around immigrants, especially marginalized, undocumented immigrants, but also Brazilian Americans who are part of the Latinx population here in the US. Because the more marginalized you are, the more excited I am to work with you, because that tells me that methodologically and our data systems are not necessarily taking you into account. One other thing, I think for me, my passion of who I am is what drives me and what I do. And I think that's an important thing. How can I say, I'm going to talk a little bit about this later, is who does the research matters, especially for marginalized communities, because as I will talk later on about that, is that those who are not necessarily part of the community can further stigmatize the community. And I want to work with researchers to really bridge that gap, to research, to practice, and practice to research. That's who I am. I want to do the good work of, what I was doing as a community organizer, but now flip it on its head as an academic.
Thank you so much, Dr. Carlos. You nailed a lot of things that I think really jumps into the next question, which is great. And one of the things that we definitely want participants to leave with is understand the historical context behind the challenges that the LGBTQ2S and BIPOC community faces. And so with that stated, what are the historical contexts needed to understand in order to impact engagement to these specific communities? What does cultural humility means, and how does this kind of like move the needle to create change, right? To create impact, to enhance engagement. What does that really look like? So because you started so gracefully, Dr. Carlos, I'm going to pose that question right back to you.
Okay, great. Okay.
3 minutes.
3 minutes. Okay, and I'm a talker, so let's go. The historical context. I'm a data person. I'm a methodologist by training. So anything around to do with queer health disparities and inequities, I'm really, really motivated by that. I am struck by a story that Dr. Satcher, David Satcher, told me when I actually was working for him years and years ago about health disparities research. This is way before doctoral school. And he said, the more research you do on a certain topic, on a certain population, and inadvertently, you are marginalizing that population by only focusing on that topic. And he used an example about African Americans and cystic fibrosis at the time in the 80s and the 90s, and he went on to talk about other examples. The example that I use with my students in my class, and so like in research methods or health disparities classes, or even social behavioral, I said, look up gay men and look up health inequities. What comes up? And inadvertently, a lot of the literature is focused on HIV, sexual health, and mental health. So I asked my students, does data work for the population or against that population? Because inadvertently, the more HIV studies you do, and by the way, I want that to occur because I want the epidemic to stop. Are we really further stigmatizing the population and looking at just as gay men as just these sexual beings? And is that who they are? Should we be looking at eating disorders? Should we be looking at, community connectedness at a more deeper level? There's been some really good work that's been done lately, but not enough. So I think for me, from the historical perspective, data is a big role in that. And I'll talk a little bit more about the role of data in health sciences and how it's actually worked against minorities. And I'm going to end real quick. Cultural humility is both a lifelong journey around awareness, but also a process that you work on every day, just like recovery. We work on it day by day. You have the 12-step program. Cultural humility for me is the same thing. And I want to be very, very quick. I will stop because I know if I bring this example, I'm going to go over my time. Do I still have time?
Yes, you do. 1 minute.
1 minute, I can do it in 1 minute. I'm a gay male. I did my dissertation on bisexual health access. And what I've noticed in the gay male community for a long, long time as a gay male, and I'm okay admitting my own faults, I was exhibiting biphobic behavior without realizing I had biphobic behavior. Because when I came out in the early 90s, late 80s, I mean, everything was very kind of developed in a certain way about what a cultural identity should be around a gay male. And we always looked at bisexuals like this. And what I realized in my research, my dissertation on bisexual health access, the stigmatization of that population and the invisibility of that population, we internally, as part of the queer community, are perpetuating phobias. And the bisexual population is a good example. I have a paper coming out soon on policies and bisexual health access that really demonstrate that they don't exist. However, I always like to look at the silver lining in life. There's wonderful, newly minted bisexual researchers that are really doing a great job. Brian Dodge, who I know well, is a good example of that. He's been a leader on this, but there's not enough. Just because you have 3 or 4, that doesn't mean you're tackling the issues of biphobia. So hopefully I was under my minute.
Thank you so much, Dr. Carlos. You said some impactful things that I think, even for me personally, I'm resonating, trying to process all of it. And I'm sure it was useful to everyone that is on here. So with that said, Dimitry, I'm curious to understand, how can we, how does engagement looks like, and how can we move that? Provided what Dr. Carlos just stated. You're muted.
Sorry. Looking from my perspective, a historical view of how we engage the communities, BIPOC and LGBT or the queer community. I'm reminded of an individual that came to the hospital one time and said, I would go to treatment, but the treatment centers that y'all offer remind me of prison. The way that we set up some kind of treatments is indicative to what we think they should be in, how they're housed, how they're treated, and they're just treated like some of them just caged like animals until we find the best treatment method for them. And so they come back in over relapse time and time again, and we still offer the same engagement to them. So I just feel as though, looking historically, that we have not shifted what treatment looks like. We have not shifted to the communities of how the best to engage of a process of recovery to you. So I think that the way that we engage the community, either the queer community or the BIPOC community, has to be from an approach of something has to change. Something has to change at the end effect of how we actually go about the process of offering treatment and what treatment looks like. 28-day treatment centers varies. It varies from depending on if you have Medicaid or if you have private insurance. And there's nothing really in between. And so since most people that have had 3 or 4 times relapse come through the emergency rooms doing overdoses, just looking statistically wise, looking at statistics, they know what treatment looks like. So historically, what do we have to do? We have to actually change the dynamics of Medicaid when it comes down to treatment centers, what is offered, what treatment looks like for those individuals. And right now is slim pickings coming from the hospital side. What I have a choice for somebody with Medicaid, sometimes it's limited between 3 and 4 places. What I have the options when it comes down to private care, it's unlimited. What a shame. What a shame, because most of the communities that I see that are BIPOC or LGBTQ, they are not privately funded through insurance. They're not, because of either mental disease, because of lack of SESs. It doesn't even matter what the cause is, it's just that they don't have it. And so if we're looking at it, it's been time and time again. If we go back to the 80s, if we go back to the 90s, the early 2000s, nothing has changed economically for these communities. So they see themselves as less than. So the treatment options for them are less than par, Nothing has changed so far. Thank you.
Thank you so very much, Dimitry, for your input on that. Dr. Ignacio, I'm curious to know, what does cultural humility means to you, and how can this be used to impact the community? From somebody of your stature and background who have done a lot of work in implementations and really moving those needles, what does that look like?
Well, thank you. You know, to me, cultural humility is really having an understanding of those historical pieces that have led people to where they are today as a client. And I'm talking specifically about colonization, but even more specifically, religious indoctrination of Native peoples 500 years ago that really shifted gender norms, if you will. It has been documented tribes have 3-4 different genders. But once religious indoctrination happened, the gender binary was forced upon. So that was a shift. But then even more recently, thinking about federal policy, actual policies to commit systematic genocide among Native people with boarding schools. And for all those who are hearing about, the terrible news coming out of Canada and certainly the lower 48 around boarding schools and unmarked graves, those policies that instituted those death camps essentially also disrupted identities and cultural identity and place and value in the world. And so then you're left with kids who are raised, within that trauma and generations of that trauma that gets passed down. So bring it to contemporary times. You factor in just trauma within your own family of what poverty can bring, of living in poverty, of being isolated, living in rural community, perhaps, and then layer on this historical trauma that's been passed down. It's not surprising one would turn to drugs and alcohol as a way to cope because it's effective, right? Then that's where kind of the rubber meets the road as providers. Working with a client who identifies as American Indian, Alaskan Native might be where you might stop and you might pursue cultural interventions. But what if we go one step further and sort of unpack that sexual identity piece? And this might be the first time a Native client might be talking about that, about their identity, about what it means to be a woman, what it means to be a man, what it means to be trans, what it means to be non-binary. What a rich and powerful space you could create for somebody who hasn't had that opportunity to have those conversations. And so to me, that's having that knowledge and sort of that awareness informs the way I interface, and I bring my humbleness to the client provider session.
Thank you so much. I appreciate it. Mrs. Anna Jones, can you please provide your input on this topic for this question as well?
Sure. Thank you, Matt. You were, I just felt that on what you were saying, because I'm in everything, and also, our other two speakers, because trauma is major. As an African-American woman, as a woman who's been through over and over relapse being a part of my story until I truly surrendered and wanted to get help and was willing to dump all that shame and guilt that I didn't want to tell anybody, right? That had happened to me in my addiction. And for me, trauma, what's trauma? Please, I don't have trauma, right? And then to really, as a woman with 22 years clean today, learning, yes, you have a lot of trauma, and it started from your childhood, right? Of how you were raised, your culture, a lot of things I didn't want to see. So for me, that question, it's just major when it deals with trauma, and it deals a lot with stigma and shame and guilt, right? And not wanting to be authentic. And us not wanting to accept people that really bring that into the fold. And for me, it's multiple pathways. It's totally multiple pathways. It's meeting people where they are, right? Understanding that everybody has a process, and Dimitry has hit on it a little bit, because we can't meet a person, a woman who's been through trauma and shame the same way we can meet someone who, hasn't been through those things, right? So, and I think we're trying to get there, honestly. I can say I'm thankful that while I'm here, because of my prevention people, connecting with them and them wanting me to connect more as a woman in recovery with the youth, with the people in the community. So it is multiple pathways. It's not just treatment, that's not the only way. What helped me as a woman in recovery, it was going deep. was meditation. It's with somatic body work. It wasn't just NA and AA, but that's what I was taught going in, right? It was like, you have to do this, you have to get a sponsor, you know, and that's not the way I treat it today. I meet people where they are. And I understand that everybody's process is different and everybody has their own story. And then that's, you know, that personal centered piece that we talk about, that we want to, you know, meet them in that way. And that's just the realness of it. So thank you, Matt, for bringing that trauma in, because I think the culture that we're talking about, definitely with BIPOC, there's a lot of trauma and there's a lot of stigma. And a lot of times we don't want to, you know, bring that up or bring that to the table. And Carlos talked about organizing. Oh my God, that is so major. That's a major part of it. That organizing, you know, mobilizing, organizing, and really being out in the front and not hiding it anymore, really talking about it. So that's my feelings on that. Thank you.
Thank you so very much, Anna. So far, I've heard an enormous amount of things, and we all know education is huge. I've heard the term education. I've heard the term in terms of there are multiple different ways of looking at things, different perspective, and perspective is huge in how a person receives things, how they understand certain things. Recovery is one aspect. Education is one aspect. And the research is another aspect to bridge that gap between how we take that research and then apply it to the evidence base to then be able to aid and help people in this process, whatever the process may be, whatever the illness may be. Those are all very important. And so given that, I want to pose this to Dr. Ignacio. Can you please offer some examples or strategies that has worked? Someone who has worked in implementing, evaluating, and structuring these kind of things.
Sure. Yeah, I like what Dr. Carlos was talking about, that this is a process. So it's an active, you are using your body as an instrument. You're using your words as an instrument. You're using your experiences as an instrument, as an art, as a provider. And so some of the things, it just goes back to the basics, which are so critical. And it might seem basic, might sound basic, but issues around confidentiality. It goes back to building trust, laying the foundation for a trustful and trusting relationship and connection. I will, you know, we might just read a confidentiality statement. Someone might sign it. We might move on to the next piece of paper that folks got to sign. But really pausing and talking about what confidentiality actually means as an organization, as a practice, and as you as a provider, as one way you can begin that conversation and increase trust. Another, for me, is follow through. When I talk with community organizations or community leaders, certainly with clients, but there are sometimes the ball gets dropped, right? Or I take a long time to return an email back to a community organization. I'm mindful of my faults because I know that doesn't do anything to build trust, right? The goal is to build trust, and if I'm not responding in a timely manner, you know, I don't want to sour any chances I got. And then the third one is, you know, making an effort to go into community spaces as an invited guest. So let's say you're non-native and you have a client who's native and they're talking about a really big community event happening this coming weekend. Everyone's invited to come. You know, it would be, I would make an effort to attend that event just as a observer. It's that cross-sharing. So folks come into your space, you know, they want to see you go into theirs. They want to see your face. They want to see that you're part of the community. And again, this is all an effort to increase trust. Thank you.
Thank you so much, Dr. Gnostic. Dr. Carlos, I'm curious to know in what ways do you think is needed to mitigate barriers and access to care, specifically in the specific community in which we're referring to, and someone who is a researcher but also does the clinical aspect, and so you are on these both spectrum. I'm curious to know your input from both standpoints.
Oh, thank you. Just to, I want to say one little thing before I jump into that this whole conversation about trauma is a very powerful conversation, and there are very many societal and cultural mechanisms that encourage trauma, and systemic and organizational. I can go on and on. But one of the things that really kind of pushes me over the edge is the erotification and exotification of queer populations. And I can go into deeper detail about that, because that in itself, the image of you, let's say if you have a Latinx man, whatever the case is, I use the case of Brazilian. In the published literature, I'm sorry?
Continue.
Okay, I'm sorry. In the published literature, basically participants talk about that kind of erotification of what a Brazilian man brings to a relationship and what does that mean. And it really is a focus on genitalia and so forth. But going back to your barriers piece, one of the things about, I tell my students, always question the question. Don't give me an answer. Question the question, because that's not good enough. And one of the things that we do in public health, we borrow from social work, we borrow from sociology, we borrow from anthropology, we borrow from psychology. And that's how we make the field of public health, and how we try to distill these issues, complex issues of health inequities. One of the things is that if you look at the evolution of sexuality studies, and I actually have to write this down because I always forget, is that early on, there was this whole science and the medicalization of sexuality through genitalia. And I have a quote, but I'm not going to read that quote because of issues of time. But there's this wonderful guy that I actually follow in La Trobe University in Melbourne, Australia. And he does this examination of what it means to be an MSM, a men having sex with men. And he basically said the identity piece has really become an issue for our in the study of the science of, let's say, LGBTQ, whatever populations, or queer populations, that the normal was heterosexual and the unnormal was anyone who is not. And that's how the foundation is to a lot of our studies. So there's this one group that's normal, and whoever else fits into that group. And the barrier is around, at least for me as an academic, really pissed off as a practitioner, is that this is not a perfect science. Even behavioral science, there's a lot of medicalization of sexual orientation and identity. This is just a process of investigation. People who do the work can actually, as I mentioned earlier, do more damage. Like I have a transgender study. I've been sitting on this data for a long time. I just refused to publish it. And I found a colleague in Northwestern, and they are actually part of the trans community. And we're going to do it together, because I don't want to be part of that paradigm of contributing to the publications and to the literature and further stigmatizing the population. That's not my role. That's not social justice. That's injustice. And I'm trying to think what else I wanted to say real quick. I talk really fast when my Northeast is in play. I think that's really it. You wanted me to talk about the barriers. You want any other examples or anything like that?
I would love to hear some examples. Do you have some time?
All right. Early on in the 90s, I was really involved with gay youth groups. Massachusetts, the Massachusetts Commission on Gay Lesbian Youth was the first in the country. So I started a couple of them, and I did that. And one of the things I found early on, because I'm a student of history also, is how can I be part of the queer community if I don't have a sense of who I am historically? I grew up ethnically and understanding what my culture is. As a gay male, how was I introduced to that? Was back then, there were very negative stereotypes about LGBTQ populations on the media. So we actually developed, and I have the curriculum somewhere, looking at developing youth programs, looking at the social and historical contexts to build resiliency and the sense of worth and identity. We would debate the meaning of gay pride. We would debate things like, who were our forefathers and our foremothers? Who were they? Marsha Johnson, is she important? If you're thinking about Sylvia Rivera, and I can go on and on and on, and thinking even back to the origin of sexuality studies, who are these people? And what does it mean for you developing your own sexual and gender minority status? And I think that's important. No, up there, it was very immigrant focused, and it was very kind of a Latin focused population. So we focused on that. Because if you don't have a sense of pride and belonging, how can you really relate? Because back then when I was out, when I go to a gay bar, I would see porn on, if you at a gay bar, that's what I saw back then. So my socialization is that gay men are just very sexual. Are we more than that? At least from a gay male perspective, I think we are. And what's our sense of history in promoting a sense of belonging and a worth? I think that's what I would actually say more than anything else when it comes to an example. I can get really passionate about this stuff, so forgive me. At least my hands are not waving in the air today.
I appreciate it, Dr. Carlos, and I'm sure everyone else does as well. Anna, I am curious to know, given that there has been a longstanding institutional racism embedded in our systems and in society, what are ways you think can mitigate these barriers to for access to care? And what examples of strategies that has worked from someone who has been a successful peer recovery individual?
Thank you. And thank you, Dr. Carlos. That was very informative. I'll speak from the heart and speak from what I've experienced. I can truly say, growing up in Washington, D.C., I didn't know as much like racism was existing like that until my freshman year of college, when I went to North Carolina and I was confronted with KKs marching down on the main street. And I was like, what the is this? How are you all letting this happen, right? So it amazes me that I wasn't even aware of that, because I grew up in the inner city of Washington, D.C., and I didn't see a lot of, things like that happening. And that is where I learned how to really start to advocate and advocate by microaggressions and people saying things to me of microaggressions to confront it and explain it, not feeling like I have to do the work, but anyone who doesn't understand about what's happening in the world dealing with racism, that they need to do the work, teaching it. In Oxford House, we've been able to do some equity things since this has been happening to open the door and be like, this is really happening. What are your feelings on it? You can't just sit still and be like, everything's okay, it's not me, because what affects me affects everybody. So this year has been sort of tough for me in dealing with that. When you said that, it just was like, oh, right? Because of all the things happening in the world when it deals with Black Lives Matter and, and how is that affecting people in recovery? Because it's definitely affecting them. Because again, feelings are popping up of I'm less than, I'm nothing, those feelings that we want to get better, what's going to be there for us when we get better, right? What do we do in that? So it's confronting it. It's not hiding it anymore, making it like it's not there, and speaking about it in a loving and caring way, so that we can grow, and that it's not hidden. And honestly, we don't see it as much. I'm not saying as much in our Oxford House realm, because we're peers. We have to confront each other like on a weekly basis and talk about what we're going through. And that's been working, but we do know it's there. And when it's there, we nip it. We don't just let it simmer like, okay, it's going to get better. It's like, nope, let's discuss it. What are you feeling? Why did you say that? And it normally stems from something that happened in childhood or how that person was raised, right? Yeah, so it's really deep. It's out there. Something needs to be done about it. We can't just say it's not happening in the world of addictions or treatment, because we're making people better. Those feelings are still there. Those stigmas are still there with that. And it totally affects women of color a lot, because I feel like we're more caregivers, and it's like, oh, I got to take care of you, or then that feeling comes in, is my child going to be okay? People in recovery are feeling that too, and we want to do more. So a lot of things that are happening in my world is we're starting to advocate, we're starting to organize, we're starting to mobilize and really talk about it. Yeah, so that's where we are with it. Thank you.
Thank you so much, Anna. I appreciate your intake on that. And let me pose the same question posed to Dimitry. Can you please highlight some ways in which we can mitigate barriers to access, specifically in these community? Someone that's coming from the BIPOC community as well. And what are examples of strategies that have worked and best practices?
Thank you so much. In the BIPOC community, I'm going to look at it from another kind of perspective. I'm going to look at systemic racism as a mechanism that doesn't have to engage anymore with us, meaning that it has done its job. It has done its job where generations that are now engaged with their own recovery don't see themselves getting any further. The system of racism doesn't have to tell you anymore to call you an N-word. It doesn't have to, because it has set the barrier up that now in your own community, you can't even get out because your mind won't let you. The mental health of breaking these barriers within the communities has to start first. Before we can engage with them, they have to believe that they're better than where they're at in their own addiction, in their own process of recovery. It doesn't matter which part they're in. They have to think and believe that they're not locked in some kind of a shackle where they cannot get out. The barrier has to start within the community. The barrier that has to be broke has to start within the community. And I don't think that's played out. I don't think that's looked at as much. We're always talking about what we have, the forces that are against us, instead of looking at what we can do within a community to overcome. I think we sell ourselves short, especially in the BIPOC community. I think that we have everything thrown at us in the kitchen sink from Washington, D.C., and yet we still have the murder rates in certain cities that are enormous. We have certain lack of overcoming skills, certain lack of mental health aspects that are not in an inviting community within our own community. Let me just share this with you. I was talking to a young lady that was coming out of our psych ED, and she told me that, you know, I'm not going to get high anymore, but I don't think my life is still going to get any better. And I'm looking at her, and she's medicated. She's been in the psych ED for days. Her medication is working, and she's talking her baseline. She's back to baseline. She's not manic. She's not depressed, and she don't believe that her life is going to get any better. So she's going to go back to the community, may or may not get high, but she's not going to take no more further steps in bettering her life because she doesn't believe she can. Systemic racism has worked. It has worked, but it's up to us, especially in the BIPOC community, to do something about it. It's not going to come from Washington. It's not going to come from the pulpit. It's going to come from the community itself, to know that we're going to take a stance in bettering ourselves from inside of our community. That's the barrier that needs to be broken. The barrier of knowing that we have to work within instead of looking from without to change our mindset. The mindset has to start within the community. If it doesn't, then even the panels and this panelists right here from PTTC, what are we going to do with the information that are presented to professionals if the communities themselves are not going to take a stand themselves? So thank you for letting me share.
Thank you so much. Thank you to everyone on this panel thus far. It's been extremely informative. Before I move along the question, does anyone have anything additional they would like to say? Okay. And so given that, what are some advice you would like to offer as professionals in this field in order to improve initial contact with members of LGBTQ2S BIPOC communities? Anna, I'll start with you.
Thank you, Princess. So my motto is always nothing for us without us. You know, I had an opportunity to work with Faces and Voices for a while, and advocacy and policy, you know, and just knowing the importance of us being at the table when it comes to anything dealing with that issue, right? And a lot of times we'll be, you know, see people talking about that and we're not at the table, right? To really express what's needed or give that lived experience, right? Of what's really happening. So I think that's a major thing. Nothing for us without us, is stepping up, being at the table. I think it's important for us to make connections, really, you know, connecting the dots. It's so many, you know, when you don't connect the dots, everything falls, right? And a lot of that is happening because we're more alike than different in the struggles and everything I'm hearing from everybody. So for me, it's connecting the dots, as a resource coordinator with Oxford House, I get to do that. I get to meet people and be, meet them right where they are and really do a wellness check and, hey, this is what you need, and make sure it is a warm handoff, not like, here, you just go here, you'll get it. You'll go here, this is what you're going to get. Are you okay with it? Not just treating people in another training, I want to treat people as a resource. Everybody is a resource. And it's just the importance of that. And again, it's community. It's community. And I see that prevention wards do a lot of that. They're working, you all are working in the community. You're right there. I know that our area, they're working in the community when it comes to working with the youth, but connect the youth to people who with lived experience so they'll know that they don't want to, go through that, or, what's happening so that person can grow from those things. Advocating is a major part. So I believe in that. I believe that will help us grow. I believe in meeting anybody where they are, because everybody's process is different. And I think we need to see that and know that one door isn't going to be the same for another person, and open that up, give the people, different options to be able to grow in their own process. Dimitry had talked about it when he said, the treatment centers are leaving us, and they really are. So where are we going to send them to now? Where are we going to send people who have been through trauma, who have been through these different struggles of life, of always, putting a mark on us, a mark of shame, or, categorizing something they know nothing about, or the experience that they know nothing about, right? So we have to realize that as practitioners, we truly have to realize that. And I think that'll, help us grow in the process. So I think that's what'll help preventionists know better. Yeah.
Thank you so much, Anna. That was deep. I appreciate that. Dr. Ignacio, I would love to hear your viewpoint on what are some advice that you will offer a new professional in the field in order to move initial contact with members of the LGBTQ BIPOC communities. Anna touched on really connecting the dots. What does that even look like? How do we break that down? I would love to hear your intake on that.
Yeah, well, I had spoke earlier about TwoSpirit individuals, and that's listed in the acronym as shorthanded as TS, or sometimes it's shorthanded as 2S, along with the other alphabet of letters that are in the acronym. So I just want to briefly talk about that because that is a contemporary term. 70s and in the 80s, Native LGBT folks identified gay, lesbian, and the mainstream, names, I guess, or labels, if you will. But in 1990, at the third International Lesbian and Gay Conference for Natives in Winnipeg, it was the elders who decided, and they had this big conversation around identity and reclaiming cultural identities. And they came up with the term TwoSpirit as a way to claim that identity. And what that really means is somebody who embodies both masculine and feminine energy. It's not necessarily talking about sexual identity or sexual orientation, but it is a reference to the energies that we carry within us. And some folks who are born male at birth have this feminine energy, and vice versa. It has become a term to embrace those who identify as LGBTQ as well. But I bring that up because as a new provider, or somebody who is maybe working with somebody who is Native for the first time and who identifies as TwoSpirit, you're in luck, because nationally speaking, there is in most major cities, there are TwoSpirit societies that are community-based and organized and have Facebook pages and are willing to talk and teach and learn and communicate and grow together. And those are great resources to do your own, to do the work that's necessary in your community to know what resources are out there. I'll just do a quick plug. I know that the TwoSpirit Society of Montana is hosting their They've been doing it for many years, and now it's back in person this year. A retreat up in Montana at the end of the summer. So things like that, activities like that that take place nationally, I think is a great space to start.
Thank you so much, Dr. Ignacio. I appreciate it. And I want to pose that same question to Dimitry.
I really think for new professionals, they have to open their mouths. They have to, like Anna was saying, be an advocate for yourself. Sometimes when we get in different spaces and we get these jobs, get certain jobs and say, you know, I want to be of service, I want to be of help. And the training, the education that we may have is not really indicative to our circumstances, meaning that it doesn't meet the spaces of our jobs. It doesn't line up. What we learned in the classroom doesn't match actual life. And so new professionals may not understand certain communities, why they're not fitting into our textbook equations of how the end result should be with certain populations. So you have to be an advocate for yourself. You have to go to the ones that are experienced in the fields that's working with certain populations that you may not fully understand. And ask the questions that are uncomfortable to ask. Those questions may be, why don't they want to talk to me? And you may be fearful of your job, but you're at that job. You're the new professional. Since you are the professional, then be a professional and open your mouth. If you don't understand why people are not engaging with you, why certain communities are not rather prefer to talk to someone else that look like them, then understand that. Understand that that is not saying that you're less than at your job. That is not saying that you're falling short engaging with them, but understand what the connections is to somebody else that is connecting with that community. Maybe it's something that you could look at yourself, or maybe it's something that you cannot. But regardless, that you're in that position. So make sure that you're advocating for yourself, that you're speaking up, and that you're still in the process of being open-minded to learn new things on that job, because it's in real life. It may not be the same way that you learn from any kind of training courses or education at any university.
Absolutely. I definitely agree with that. And Dr. Carlos, last but not least.
No, this is actually really good. I'm actually piggybacking a lot of the rich information that was just said. One thing I had to write down is everyone's a resource. That's what Anna said. And I got stuck with that because I'm always thinking about me as a practitioner and also as an academic. What does that really mean? The only way I succeeded as an academic, as a professional, was mentorship. I was mentored by other queer professionals. And I think that really opened my eyes. Even now, I have mentorship at different levels. Now, this is the thing. Mentorship happens formally and informally. Where formally you have like a relationship, you have an agenda, you work on a plan, whatever the case is. Informally, it's just tapping a person to ask a question, as Dimitry was saying. And also, let's say if you have a question about the Native population, as Matt was saying, that's important. Is how do you incorporate mentorship into your life, and how do you view that as a personal growth? Now, mentorship can be in different ways. Individually, we talked about asking questions. Organizationally, you have affinity groups. If you're struggling with data collection, and how do you capture this huge population that's so diverse, is thinking about inviting the community to the table to really help you craft that. That's powerful. We talked about cultural humility. The first person I walk into in the doctor's office is not to see the doctor. The first person I see is the person who is basically, checking me in. How that's facilitated and done can make it or break it. And I've actually changed doctors because of that. My dermatologist, I can get into this details, might be more personal. She thought I was married to a woman. I'm like, okay, I don't know where she got that information from, but that's some of the stuff that happens. So the question is, how do you approach this, not only from a mentorship piece, but from an organizational piece? How do you start switching things slowly, how do you approach populations, as has been said, to really be more welcoming? I think that's really it. I just want to make sure we have enough time to hear participants' questions. So,
Thank you so very much. Again, panelists, I appreciate you all. I'm sure this has been one of the most insightful conversation and webinar I've attended and even moderated. So, and I hope as attendees, the chat has been live. I hope you all have enjoyed today's conversation as well. And please make sure that you tune into part 2, 3, and 4. But moving on with the Q&A, because we do have some Q&A in the chat. I'm going to start with the Q&A in the chat and then move to the chat as well, okay? So the first question that was posed was from Daisy. Marines, I apologize if I enunciate your last name incorrectly, but the question was, what is court intervention? I noticed Dr. Matt used a term along these words when working with clients who are, for example, Indian American.
So the cultural intervention, I was just thinking of an example. If you're working with a client who is wanting to address some aspect of their drug and alcohol use, and they want something that's relevant to their American Indian Alaska Native heritage. So you as the provider might look up locally and find out that there's a Native organization that's offering a drumming group for folks who want to address drug and alcohol use. So you might make that referral and stop there. That would be an example of a cultural intervention. What I was suggesting is really going a step further and talking about sexuality. I mean, it can be a taboo subject. I'm not saying it's an easy, it's not always an easy conversation to navigate, but it's about creating that opportunity of healing for somebody who may not have had that opportunity to have these discussions, particularly in stigmatized communities. May not want to come out and disclose information to family and friends because they live in a small community. But you as an outsider or somebody who's not from the community could be a trusted ear and source and person to talk with.
Thank you so much, Doctor. The next question that was posed specifically to Dr. Carlos, it was from Juan Carlos, and he says, is Dr. Carlos saying that bi and trans research studies should be done by bi and trans researcher precisely? And would there be a benefit to that?
So this is a complicated question. And I always, depending who the audience is, if you're an academic, people's feathers get ruffled. If you're a community person, they're like, yeah, I should be at the table. Let me just be at the table and help you craft what you need to craft. So ideally, if you're doing work with marginalized populations, they should be at the table to help craft things. So for example, there's a lot of studies that have been published around transgender communities that are good, but they miss some kind of nuances about what does it really mean being part of the trans community. And are they really being stigmatized by the survey questions that they're answering, or how the research is being written? I think that's important. It's almost like getting a filter and approval from the community. Now, some folks in academia will kind of blow back and say, well, that means that if I am a white person and I want to do work with the African-American population, you tell me I can't do that? I'm not saying not to do that. I'm saying be inclusive in your team and how you disseminate the research. Make sure that those voices are not just written from your perspective, but they're also reflective about what the community really says. I mean, there's a whole school of thought around community-based participatory research. I've had long debates with folks in academia about this because they feel like, I personally think for me, is that when those debates come out, it's what's the question you're trying, like what's so threatening to you by inviting someone part of that community there? What's so threatening? Bisexual piece, like my dissertation, I could have been an associate professor by now on my way to being a professor, but I'm not. You know why? Because I spent 4 years with the bisexual community to really understand what it means to be bisexual. It would have been very easy for me to collect the data and boom, turn it out and publish it. And that's not the case. If you're going to do the work, you have to do, for me personally, doing the work has meaning, but also it should be grounded in some sort of ethical and also social justice meaning. As I mentioned earlier with Dr. Satcher, is just because you publish doesn't mean it's a biblical scripture. And if you publish, are you really adding more of the stigmatization of the population? Some people would argue with me with that. I approach public health and I approach my profession really grounded in social justice because I know what it's like to be marginalized. I read studies about who I am, and some of the stuff I just don't understand why it's being said the way it is, because I think they missed the points. That's my point to that. I hope I answered your question, Juan Carlos. I like your middle name, by the way.
He said you did, thank you, in
Okay.
the chat. The next question, thank you, Dr. Carlos, as well. The next question was, how would you recommend, this is for anyone, all of you guys, how would you recommend going about picking mentors to help me make sure I am practicing cultural humility? That's a great question. Anyone can speak. Dr. Carlos is thinking deep.
I'll speak. I'll just say, as far as mentor, you want to get someone with lived experience, you know, and it's an honor for you to be able to step up and really put yourself out there and ask. But any mentor that I'm going to choose has, you know, been through it and knows, you know, and I'm going to be correct of what I'm expecting from that person, you know, and it's a person that I admire, a person like Dr. Carlos was talking about. That's so real. Nothing for us without us. Who's been at the table and really can, you know, guide you on and doesn't mind being honest about their personal experience. So, yeah.
I think that no matter if you're looking for a mentor in academic spaces or just in personal life or engaging in your own recovery, they have to be honest. They have to be transparent, no matter what, even in the hard conversations of who they are, who they think they want to become, and even in their struggles. Because if they're not, they're doing you a disservice and they're not your mentor. And it's not somebody you should be gravitating to, my own personal opinion.
There's a weird dynamic in mentorship. It's like dating. You're afraid to get that no. Like, oh my God, they're gonna reject me. You know, so what? If they say I can't do it, life goes on. So I think for mentorship, it's thinking about one person and one issue that you want to talk through with them, and also not wanting anything in return. That's what I tell my students. Look somebody up, look at their resumes, reach out to them, never ask for a job, never ask that you want anything from them. Ask how they got to where they got to, because people like talking about themselves, and that is a way to build a mentorship piece. I also want to flip, sorry, my microphone. I also want to flip this, because I sometimes think we think mentorship is like a top-down thing. Oh, no. I've had mentors that were other community members when I was a community member. You know what I mean? I had mentors when I'm in academia, like now, I look at them to help me figure community dynamics. So mentorship is really an informal process, and it really just is conversation. In basic essence, like dating, you're gonna meet somebody for coffee or dinner, say, I would like to have coffee. Well, I don't know if we can do that today anyway, but say you wanna have virtual coffee and just ask them questions. And then from there, build a relationship. But I think it's the mentorship piece, what it did, it made me feel normal in the struggles that I was going through as a gay male, as a professional, but also it made me dream. And that was really inspiring to me as a person. The person who pushed me to get my doctoral degree, she mentors me today. I call her up, she's retired. Iris, I need help. She's not gay, but she's there for that one piece. Does that make sense? I hope that makes sense to folks. I do not explain it any other way.
That's great. It makes sense to me. Thank you so much to all. The next question that we have is, what are the top things masters in social work students should do to ensure that they are able to apply the information you all shared today in schools and internship?
That's for me.
Dr. Matt.
What can we do to ensure MSW students, graduate students in general, folks who are going to be out on the field providing direct services? I mean, we talked about doing your own research, finding your own mentors, and you got to do the legwork. But it is also, I'm just sort of thinking, really, to me, I would say, like, yes, all that, but also you as a person, what is your skill set around developing relationships with clients in a therapeutic way? Like, what is your skill set around that? How are you able to engage folks, who may come in different states of being? Are you able to pivot quickly? Maybe, are you nimble as a provider? I think that nimbleness to be able to respond to a wide range of clients is an internal thing, and just to kind of, it's fun. I like it. It's sharpening your instrument, and part of that is also your dedication to quote unquote self-care, but it is really being intentional about your own healing practices so that you then are able to stand on 2 feet to be able to do the work that you need to do.
I agree with that personally and professionally in where I'm at right now. The next question is posed to Dr. Carlos. It said, can you give specific example of how including the community helped benefit the research you did?
So I was involved with the bisexual community for a number of years. And what I noticed with Carlos was that one of my key mentors is always identified as a gay male. Is a father, has a child, was married to a woman, but I was always been socialized as a gay male and really is bisexual. And I was in shock. And then another friend, I remember was doing some work with actually the gay men's health crisis. And I was in New York and I met another friend, and she dated women when she was young. And I was encouraging to go back to a certain girlfriend. And I realized, and that's not where she's at. She doesn't identify as bisexual, she's heterosexual. And I saw her really uncomfortable in front of me. And then I realized the damage that I was doing, that I have some stuff here that I have to think through. And that kind of spurred a lot of the issues around doing bisexual. And I was also in a relationship with a guy for 5 years. Like one day he told me you're bisexual. And I'm like, what do you mean you're bisexual? You're not bisexual. You can't be bisexual. And I had stuff, and I'm okay having stuff. But I did the research to explore this. Why bisexuals need to feel to feel this issue to hide. And I spent 4 years with the bisexual community. My study was really bizarre because it was all African-American. I think I had one Puerto Rican in the study, and about 8 transgender individuals. And what I noticed is that the issues that they go through, it's not like, it was actually a qualitative study. The voices, they're lost. And even in the literature, because we look at MSM, we say gay and bisexual males or whatever the case is with women, but you're not really giving credence or voices to that community. So the importance of working with a community is this, is to hear their narratives and to hear whether or not yourself, in a very reflective modality, what are your hangups? How are you viewing this? And by spending more time with the bisexual community made me realize how I do this work has to be very, very protracted, but also very meaningful and impactful for them. And that's by hearing their voices. So including them only adds more to and by the way, by spending more time with them, I got more rich. Like I actually have to do an article, what does it mean to be trans and bi at the same time? That's gonna be sometime next year, but that's the meaning, because I really got to know them. And I also asked stupid questions that I thought was stupid, and then they helped me educate myself. So I'm okay being vulnerable. It's okay, as long as they know that I'm actually on a path to growth. I hope I'm answering questions.
You are. Thank you so much. Let me double check to see if there's any more questions. Right now I'm going through the chat to see if there's any more further question. Dr. Ignacio, can you please talk more about the TwoSpirit terminology, or do you think it's clear? Is clear? That was the question that was posed in the chat.
The reclaiming of that identity speaks to a time before colonization when folks who had gender expressions that were not on the binary also had sacred roles within the community. These were the counselors. These were the folks who took care of children. These are the folks who were the undertakers. These are the folks who were the traditional healers. Folks who had Two-Spirit identities before colonization were honored and revered and were part of the circle. it was after colonization when the identity in that role was lost and stigma and homophobia and biphobia and transphobia rolled in. So that contemporary term Two-Spirit is a way to reclaim that honored place in society.
Yeah.
Thank you so very much. I appreciate that. I'm going through the chat now as we have a few minutes to make sure I catch everyone's questions. Please feel free to send your Q&A in the Q&A box that is located below next to the participant. It's easier for me to capture everyone, but I am going through the chat right now to make sure I got everyone. Thank you so much for your patience.
I just want to say thank you for putting this together. And it was an honor to present with the panelists, you know, and I talk about journeying. I learned something new today, and and that's what this is all about. So thank you.
Thank you so much, Dr. Carlos. I want to read one of the comments. I don't see any questions, but there were some really great comments in form of engagement with things that was being said today. Someone said, I believe he's saying that he does not want to publish his research on bi or trans community along from the outside work together with bi and trans individual research input collaboration. Do you want to give more details to that or clarify that, Dr. Carlos?
I think that was from Juan Carlos, is that correct?
It just said from C to panelists and attendees. And then from D, there's a conversation there kept trying to get clarity on what you mentioned.
In other words, invite the minority, invite the population of study to the table to help you craft the questions. But also, if you can't do that, because it's a lot of work, it's at least take the information, not the information, the articles that you want to publish, and have it run by a couple individuals, even researchers who are, let's say, that you're not collaborating, have them review your article. That's my point, is just get we talked about cultural humility, get an extra filter. You know, don't rush the publication, because when someone cites that, you know, you could be causing, the reviewers might not know. You might not be lucky to get someone who is an expert in bisexuality to review your work. So depending on the journal, of course. I hope that makes sense.
Someone else said, I actually agree. I think that Black men, I presume this is in regards to Dimitry. I think that Black men should be doing research on Black men, lesbian women on lesbian women, etc. Dr. Carlos' point, trans women should be doing their research on Christ women, not saying that Christ person cannot do cure research, but it is certainly knock out a lot of probables, ignorance, and assumptions. What are your thoughts on that, panelists?
Well, this past semester, I did some research on minorities and their hesitancy to become vaccinated, COVID-19 vaccines. And to engage the community, you had to talk to the community. So I had to find out through different studies and actually engaging with BIPOC individuals on why they did not want to become vaccinated. And from that information, it was laid out very clear on their stance. It's the same way what Dr. Carlos was saying earlier. You cannot just bring from a research or have it become published, and without engaging in that community. It's missing a mark there. It's missing a mark. It's not, Dr. Carlos, I do not believe is saying that you cannot do the work, but the people of that community need to be involved in the work.
Can I quickly give an example to that? I am a reviewer for NIH grants. I have seen, and I'm brought in because of marginalized communities, when there's anything with Native populations, because they use non-traditional in their terminology methods to do the work, not necessarily a randomized control trial, they go like this. And I have seen some amazing stuff out of the university. Like, there's a powerhouse out of University of Washington, and because what they approach and what the traditional science says, the reviewers don't necessarily understand. So that's how things kind of sink. And I'm trying to be very generic and not give any detailed examples. I've also seen collaboratives between tribal universities, wonderful stuff. And I'm usually one of the two actually advocating for it. But because they're using different methodological approaches, it kind of weighs down. So that's just an example. So if you're going to be doing work on with gender and sexual minorities, you have to be careful. There's a game to be played about the science of the science, but there's also this other game of like, and I call that a game that's really kind of like, how do you do the good work? And I'm still struggling with that. Like, you know, where's the middle line? Sometimes you just have to take a stance. And sometimes if you don't get funded, then you took a stance. But, you know, are we really moving ahead to mitigate health inequities? I don't know the answer. You know, it's a struggle.
Thank you so much, Dr. Carlos and Dimitry, and all for your responses thus far. To move along things, next comment was, yes, Dimitry, as a community, as the community affected, we are the professional, more community panels and the whole community roundtable. All throughout these comments, everyone said that they loved today's webinar. They have enjoyed it. It was insightful. It was informative. They really appreciate it. They appreciate the panelists. They appreciate what they're gaining with the information that they're leaving with. Just want to say that. There was another comment that said, that is a big wish. I have been watching the institution and pharmaceutical industries grow. How can we grade places that actually have LGBTQS plus inclusivity and affirming programs, not just given the advertisement without actually providing the safety and programming? I was reading the chat. I hope that made sense. So essentially they're asking, saying that, you know, there's a lot of talks, we say a lot of things, but how can we really diversify this? What affirming programs can really be, as strategies can be implemented to move along some form of change? Of course, providing that safety is included, I believe. Who would like to answer? Anyone?
I know it's something that we're doing in our area that wasn't mentioned, and it's really been an avenue of wealth to really tap into the community, is listening sessions, you know, holding listening sessions and really inviting the community to come and really talk, and then seeing what's needed, you know, and maybe taking 4 things out, and you're just sitting back and you're like putting the question out and you're really listening to what the community is saying. And that can be part of the LGBT community, the BIPOC community. It can just bring them to the table, doing the listening session. And we've done about 3, and it's really brought some avenues to the table of what's needed. And it's not normally what we think most people want. You know, it's certain things happening in a certain area, and that's what needs to be tapped into. So I do want to bring listening sessions in as a resource.
Thank you so very much. Anyone wants to add to that? All righty. Again, thank you, panelists, for joining today's discussion. It has been nothing short but informative, insightful, and a wealth of knowledge has been spilled today. And I'm sure everyone who attended to this webinar has appreciated from all of the centers. We thank you again. At this point, I'm going to move the channel to Doka, who will be taking over from the remaining of today's webinar.
Thank you, Princess, and all the panelists. What a wonderful conversation. It's amazing. Thank you so much for the work that you are doing in the community, for helping us to provide tools, information, education, cultural humility. Oh, wow, we talk about everything. So thank you so much for this conversation. Over here in the screen, you are seeing the panelists' contact information. So you probably, we try to answer all the questions, to read all the comments, but if you have any urgency and you need to contact them, feel free to do it. Over here is the link for the next 3 sessions. Please join us for session 2, session 3, and session 4. You can click in the link, and also thank you to Francesca, who helped us to put all the links in the chat as well. And here is the contact information. You will see the contact information in the following 3 slides. You will see the contact information for each center. So feel free to reach out for more information about projects, to request training and technical assistance that is free of charge. And now, thank you again, everyone. Now you will be redirected to another different page to complete the evaluation. Please remember that this evaluation is important for us. Your opinion is very important. So try to take time to complete the evaluation. Once again, thank you for joining us during our event. Thank you, gracias, and obrigado.